I want to welcome you to Research America's National Health Research Forum. I'm Mike Coburn, Executive Vice President of Research America, and I'm pleased that you're with us today. This morning we'll have a keynote speaker followed by some networking time and then terrific panel discussions throughout the day, so I hope it's a very enjoyable day for you. At this time, I would like to turn the podium over to Research America board member Dr. Al Reese, who is the Executive Vice President for Medical Affairs and the John and Akiko Bowers Distinguished Professor and Dean at the University of Maryland School of Medicine. Dr. Reese.
Thank you. Thank you, Mike. Good morning, everyone. Good morning. It's good to see so many of you here to this special event. My task is to introduce to you our keynote speaker this morning, and I'm deeply honored to do so, to present to you Dr. Robert Redfield, who has been a very good friend for many years and a long-time University of Maryland colleague. As you know, Dr. Redfield is now the director of the United States Centers for Disease Control and Prevention. He has been a public health leader and has been actively engaged in clinical research and clinical care of patients with chronic viral infections and infectious diseases in general, and HIV/AIDS in particular. This effort he has forged for over 3 decades. Dr. Redfield has been at the forefront of the fight against infectious disease research since the very beginning of his outstanding career. He served as the founding director of the Department of Retroviral Research within the U.S. military's HIV research program, and has provided 20 years of service to the U.S. Army Medical Corps. Dr. Redfield went on to co-found the University of Maryland School of Medicine's Institute of Human Virology in 1966 with Dr. William Blattner and Dr. Robert Gallo. During his many years at the University of Maryland School of Medicine, he served as the Chief of Infectious Diseases, Vice Chair of the Department of Medicine, and also as Associate Director of the Institute of Human Virology, which he co-founded. Dr. Redfield has made several important early contributions to the scientific understanding of HIV/AIDS, including the demonstration of the importance of heterosexual transmission, the development of the Walter Reed staging system for HIV infection, and the demonstration of active viral replication in all stages of HIV infection. Through his vision and leadership, Dr. Redfield successfully secured multi-million-dollar grants from the PEPFAR program, allowing the School of Medicine's expertise to be leveraged to treat and care for hundreds of thousands of HIV/AIDS patients throughout Africa and the Caribbean. In addition, Dr. Redfield also oversaw an extensive clinical program providing HIV care and treatment to more than 5,000 patients in the Baltimore, Washington, D.C. area. Recognized for his leadership in the field, Dr. Redfield served as a member of the President's Advisory Council on HIV/AIDS from 2005 to 2009. He was appointed as chair of the International Subcommittee from 2006 to 2009. He's past member of the National Institutes of Health Office of AIDS Research Advisory Council and the Fogarty International Center Advisory Board, as well as past member of the Advisory Anti-Infective Agent Committee of the Food and Drug Administration. Ladies and gentlemen, it gives me great pleasure and indeed an honor for me to present to you Dr. Robert Redfield, the CDC's Director General. Dr. Redfield.
Well, I want to thank Dean Reese for the introduction. I obviously want to thank Mary for the opportunity to be here today. It's a great honor to get to address all of you. I also want to thank each of you for your persistence and commitment to science and public health. Science is the underpinning of medicine and public health. Personally, I believe this is a very exciting time a time of great expectation about the growing potential of science to provide solutions to what really just a decade ago seemed like science fiction. When I look back, I kind of reflect on science, and I go back to think about the history of Alexander Fleming in 1928 at St. Mary's Hospital in London, where he noticed a mold on a petri dish. And around that mold, he noticed there was an impact on bacterial growth. And despite this discovery, and his own understanding at the time of its therapeutic potential in 1928, this discovery literally sat on the shelf until it was embraced during World War II. Part of the message that I want to have today is that we need to actively engage new science and put it into timely action to provide meaningful solutions. Because science on the shelf, in my view, has little value. But science in action can change the human condition. For me personally, it's been a great privilege to be given the opportunity to work with my colleagues at CDC and serve as the director for the time that I have. Those of you who know CDC know that it is science-based, it's data-driven, and it's a service organization. When you're in these jobs, one of the hard things to realize is that they're very temporal, and you have to focus if you want to get something accomplished and really pick things that are important so the person that follows you also sees them as important. And so in doing so, I came up with really 4 major priorities that I would like to focus on during the time I get to be CDC director. And the first and most important was to effectively respond to outbreaks. And who knew that the outbreak that myself as an infectious disease trained physician would be asked to lead, the public health crisis of our time, is the opioid and drug use epidemic in our nation. The second was to eliminate disease, and particularly to put science into action where we have solutions to eliminate disease and improve the human condition. The third was to secure our global health and domestic preparedness. And the fourth, and I think the most important, and the one I hope that when people look back at my time see that I helped really get this concretized, is that we need to invest in the core capabilities required for public health. And those core capabilities are really 3. We need data and data analytics. We need to modernize our data capacity, not just for CDC, but for the public health infrastructure of this nation. We need laboratory capability, and we need to keep up with it. I was recently at a Homeland Security non-classified briefing, and we were talking about our BioWatch program that we put in 2003 in this country, and I was pretty familiar with that technology, but I asked them to tell me what the technology was now in 2018, or 19 when they briefed me. And they said, well, it's the same. And my colleague took out his iPhone, he said, in 2003 I didn't have one of these iPhones. And now I'm on my 10th edition. We got to invest in the laboratory so it stays up to give the capacity to operational public health. And finally, the most important is that we have to continue to invest in creating the public health workforce that we need for this nation. I believe this is an exciting time for public health. This is an opportunity for us to revitalize the public health infrastructure of our nation. And I do believe it's something that to this date continues to be underinvested in. When I look at some of those, I wanted to highlight just a few. Eliminating disease, for me, it really was important when the President announced at the State of the Union the decision for our nation to bring an end to the HIV epidemic in this nation over the next 10 years. Because we have the tools. You know, we've had decades of science that took HIV from really a very difficult disease to be a physician as I was back in the early 80s where most of my patients died, to see now that science produced by decades of investment make it so you can now live a natural lifetime, and actually if you're treated successfully you're no longer able to transmit to somebody else, as well as developing prevention strategies. And so we've initiated a really highly targeted program which is no longer aspirational, it's very pragmatic. It's now no longer about wishing that we can create new things in science. It's strictly, the time is now to put that science in action, and it's now all about execution. The other area in eliminating disease that I've got very focused on, and I really never thought we'd be here, WHO declared vaccine hesitancy as one of the 10 most serious global health threats in the world. And that is to get individuals to embrace the most powerful tool we have to eliminate disease. And it's actually the only tool that I know of that's been successful in actually eradicating disease, and that's vaccination. And we need to begin to focus heavily on that. And again, I know this group is very involved in that, and look forward to working with you as we begin to convert more and more of those individuals that are hesitant to accept vaccines to embrace these, so we no longer have to confront what we're confronting now, which is a global measles outbreak, which could actually lead to the United States losing its status as being measles-free, as the UK did just several weeks ago. And who would believe we have vaccines now that actually can prevent cancer? I mean, who wouldn't want their children vaccinated to prevent cancer? And so again, getting human papillomavirus vaccine embraced by boys and girls to prevent the cancers they cause is an important priority for me. The other area I mentioned was securing global security. I'm just going to comment briefly. Obviously, many of you have read about the Ebola outbreak. I will say this is the most complex outbreak that the world has seen from a response perspective. It's occurring in an area now that's been at active conflict now for over 25 years. We're over 3,000 cases. It's now diffuse. It's into 29 health zones, and it's obviously well on its way in its second year, and really there's no end in sight of the current Ebola outbreak. I bring it up because it's a really important example of science in action. Here you're in a conflict zone. Here you're in one of the most complex outbreaks in the world, and yet what's happening? Clinical research. When you look at the research done to evaluate the Merck vaccine, that research was done in front of that outbreak. It wasn't waited till the outbreak was over and then we'll do some research trials. It was done right in the midst of the outbreak, and has really led to an understanding that this vaccine, in fact, is efficacious, and I think will lead soon to the approval of the vaccine. Even more importantly, the work Tony Fauci and his group have done in looking at therapeutics, 4 major therapeutics, studied in a war zone, in a randomized double-blinded placebo-controlled trial, to show, as many of you know, that we now have 2 outstanding drugs that can be used to treat treat Ebola. And with data suggesting now that the overall mortality was 60, 70% in individuals in rural hospitals that are really not that sophisticated, being treated with these antibodies have now been shown to have a 89 to 94% survival rate. It's remarkable. Didn't wait for the perfect setting to do research. It put science in action, and it's going to make a difference for many to come. I use that because the outbreak of our time is the opioid outbreak. And I'm going to stress that I think there's a lot of lessons for us from what we learned in the Ebola outbreak. We don't need to wait for the perfect solution to the challenges that we have with opioid and drug use disorder. We need to embrace science, bring it into the field, do the operational clinical research in the context of our response, and advance this. As you know, right now, it is the public health crisis of our time. It's hard to believe 130 people die each day in our country from drug overdose. We are making progress. This year, it looks like overdose deaths are down by 5%, but we got a long way to go. But I do think that we need to stay focused. I can remember when I started as an AIDS physician in 1983, my patients had a 10-month survival. And look at where we are today. Again, the same has to be said for those individuals that are confronting opioid addiction or drug use disorder. And for us, you've heard me say this before, the first thing that we all need to do is recognize it for what it is. It's a chronic medical condition. It's not just a chronic medical condition. It's a chronic relapsing medical condition. We need to embrace it for what it is. It's not a moral failing. And we need now to put the power of science behind this so that we can provide long-term solutions to this medical condition. And in the medical conditions of drug use disorder that are following, very discouraged on the one hand that now methamphetamine is the leading cause of death now in more than 8 states in our country. And science has a long way to go to give us medical interventions for methamphetamine addiction. But then I would just encourage us to realize that if WHO and NIH can figure out how to do science that makes meaningful impact in the midst of an Ebola outbreak in the DRC, we should be able to figure out how to bring science into meaningful impact in our armamentarium against drug use disorder. Finally, I just sort of reflect back on science, and many people have heard me talk. I said the most important thing is to see the possible and then lead to action. And the example I like to use is polio, 1983, 350,000 worldwide cases of polio. It wasn't WHO or CDC or NIH that's decided to do this. It was actually a group of international Rotarians that sat around and said, you know what we're going to do? We're going to end polio in the world. And truth is, as we sit here today, there's 73 cases in 2 countries, Pakistan and Afghanistan, and we are on the road to bring an end to polio in the world as a consequence of putting the science of polio vaccination into action. And it's still a way to go, but again, as I always say, when we decide to eradicate a disease, we need to stick with it until we accomplish that goal and do just that, eradicate the disease. In closing, I would just like to first take a second to thank all of you, Mary and her team, Research America, all of you that have done so much to bring the 21st Century Cure Act into reality. Again, I've made the comments that it's an exciting time for public health. It's an exciting time for science. I see major transitions in public health coming as we take our disease-based health system and we refocus it into a health and prevention system. It's an exciting time for science to provide the foundation for that as we see a focus now on disease prevention and health as opposed to treating disease. But I also think, and Mary's heard me say this, it's time for us to think about the 21st century implementation of the Cure Act. It's not good for science to just sit on the shelf, as I started. And I use the example for those of you who don't think that that's a big issue. I use the example of hepatitis C. Curative therapy discovered in 2013. 2 to 3 million Americans, people living in this country alone with hepatitis C. Less than a quarter have been treated and cured. 18,000 died in 2017, and we've had a cure on the shelf. Now, I know it's not easy, but I do think that we can collectively come together and try to see how, when we do have cures, for example, let's say someone cured addiction tomorrow, how do we apply those cures? How do we get a mechanism to come together collectively to see that these cures can be put into action to improve the human condition in real time for all of those who are in need? And finally, I just want to thank you for your support of science and public health. I think together, grounded in science and public health, we will continue to make what many see as impossible a reality. So thank you very much. I'm happy to take a couple questions. I think I have a couple minutes for questions if people want. The dean will be surprised that I actually ended on time. You've seen me talk before. I've been trained more, Al, since I've been at CDC. They're very big on that. But if there are any questions, I'd be happy to take a question or two. If not, I want to thank you very much. Thank you. Oh, go ahead. I'm sorry.
I'll ask a question. I was wondering if there's a microphone, but just send the name of the colleges of pharmacy. Thank you very much. You didn't mention chronic disease per se, and I know that among your priorities in prevention is prediabetes. Would you just say a little bit about that work?
Yeah, I think first it's important when I'm not excluding, when you get an opportunity like this, you're trying to focus. I said my gravestone's going to have my name, my dates, and the word focus. I was telling Mary I actually have 35 things in my book that I want to get accomplished while I'm here, okay? And chronic disease is really important, as you know. I encourage people to start to look at a strategic plan that we put together. Diabetes is one of them. Try to reduce diabetes by 300,000 pre-diabetics is part of our target. I think that is the big one we're targeting, although you can see the overlap with obesity. The other one I will tell you that is really important, that we're really on top of targeting, is tobacco products. And particularly, if you see now with the new epidemic that we're confronted now, it's kind of like in medicine we learn always do no harm. So we got an off-ramp for individuals with combustible cigarettes, but unfortunately it's become an on-ramp to nicotine addiction, to millions of young people in both middle schools and high schools at a rate we've never seen tobacco. So it's important, it's there. We're going to continue to try to move both tobacco use products as a major priority, and as you mentioned, diabetes. Love to see the nutrition industry want to partner with us in an effective way. I think historically that has not really happened. I think it's a great time for that to happen, because diabetes and obesity, obviously childhood obesity, are big problems. Yep.
I just wondered, could you elaborate a little bit more on how you're going to tackle the opioid crisis? What are the strategies you're putting in place for to tackle the opioid crisis?
Yeah, I mean, the opioid response, as you know, it's really escalated to a presidential issue. It's a whole of government approach. Actually, the president just announced another $1.8 billion yesterday to come out through both SAMHSA for treatment and for CDC, largely to help us with giving the states the ability to link people into, do surveillance and link people into care and treatment. And for CDC, per se, our role in this broader government strategy is first to improve surveillance so we know where the problem is, to actually get that surveillance and data such a way that it's not historical, that it actually is not even just actionable in real time, but it's actually predictive. Many of you have been reading about some of the outbreaks we're currently having in West Virginia, for example. Being able to be, being on top of and predictive, and developing what we call rapid response teams that are going in to help the public health community actually respond effectively in getting people into care and treatment. Clearly, we've done a lot to try to bring science into action with naloxone. We've asked people to co-prescribe naloxone and opioids. We've made some progress, but we've got a long way to go. Only about 1 out of 60, 1 out of 70 are co-prescribing. I'd like it to be 60 out of 60 or 70 out of 70. We've done a lot with the prescription drug monitoring program so that there's a more awareness among providers and pharmacies. We've seen an overall downturn about between 20 and 25% now of these prescriptions. Many of you have read some of the statistics that are hard to believe. I was just talking to someone on the way in. How can you have like 100 prescription tablets per citizen? Or how can you find a pharmacy in West Virginia that dispensed 21 million pills for a town that had less than 3,000 people? So again, monitoring this and trying to bring a social conscience into this. We've also done a lot in trying to make the healthcare professionals aware of the addiction. I have to admit, as a doctor, I didn't know that a single prescription from opioids carried a 2 to 6% risk of long-term addiction to opioids. I mean, if I had understood that at medical school, I don't think I'd be prescribing very many opioids. I just had major dental surgery yesterday. I didn't know if I'd be able to talk today. They took out bone, they took out gum. And when I was finished, I was a little agonized, and the dentist looked at me and he said, "Here's some ibuprofen." And I said, "Do you do anything with opioids anymore?" He said, "Absolutely not. We give you ibuprofen, and if it's really still painful, we're going to tell you to take Tylenol." I think that's a big step forward. And finally, we're trying to educate the American public. And this is not to say the criticism that we take that we're trying to take away pain control for people that have chronic pain. There's 1 to 3 million people that have chronic opioid-dependent pain. No, it's for them and their physicians to figure out how to provide that pain. Although I would like third-party payers to be able to reimburse for alternatives like acupuncture, massage, and different types of therapy, and not have the only therapeutic intervention that they'll reimburse for is opioids. So again, when this is how we're trying to do this, it's going to be a long battle. What I do try to tell people, and people know that I've experienced this in my own life. I thought as a doctor in Baltimore I knew addiction because Baltimore clearly had its share of it, and myself as an AIDS doctor saw a lot of it. I didn't understand the complexity of the addiction until it almost took the life of one of my own children. And I understand it now at a palpable level. And that's why I say we need to embrace individuals. You don't identify somebody, oh, you're a diabetic. Oh, yeah, you're a cancer patient. You're an addict. No, we need to let people rediscover the joy of who they are and help them confront their chronic medical condition. And I will say, as a family member that's in it, addiction's a family disease. It's a family medical condition. We need to support those families. So I do think it's really important that we begin to create that climate. But for families like mine, that we put out there the hope that science is going to provide the solutions. I think it's just a matter of time that we'll have mechanisms to treat pain that don't have addictive potential. I think it's only a matter of time for us to understand the interrelationship between gambling addiction, sex addiction, drug addiction, alcohol addiction. I do suspect there are common pathways. And I think it's going to be an exciting time when science finally, it's one of the things that I hope the 21st Century Cure Act actually figures out, because I think it will be a really important discovery for our nation and the world. All right, thank you very much.
Well, we greatly thank you, Director Redfield is out the door, for your extraordinary leadership. You've got a lot of allies and friends in this room. I know we're all pledged to help him and his colleagues deliver on very real hope. You know, there is every reason, I think, and we heard him say it today, for hope if we pledge as a nation to put science to work, make it actionable and act on it, and assure that the resources are there that permit public health to succeed. It's absolutely doable. You know, it really is, I think, an extraordinary agency, the Centers for Disease Control and Prevention and Protection, might also have that extra P put there, making a huge difference for what really is a very small budget. It ought to be bigger and better. And I know that many of you are joining us at Research America and pushing for that to happen. So we do thank the director for taking time on his schedule to join us and setting up a kind of challenge for the panels we're going to hear. I'd like to ask now Parul Patel, the Senior Director of Federal Government Affairs and Policies with Horizon Therapeutics, to make just a few remarks as the sponsor of this breakfast session. Parul.
Thank you, Mary. Appreciate that. Appreciate the introduction. We at Horizon, we're honored to help welcome everyone to the Research America National Health Research Forum this year. As Mary mentioned, my name is Parul Patel. I'm with Horizon Therapeutics, and I'm on the Federal Government Affairs team here in DC. For those of you not familiar with Horizon, we're a biopharmaceutical company established about 11 years ago, and our areas of focus are to research, develop, and commercialize products in both the rare and rheumatic disease space. And it's our focus there that leads us to work with those patient communities as well. At Horizon, we believe that science and compassion must work together to transform lives. And that's especially true in the rare disease space. I'm sure those of you that are focused in those areas understand that as well. And as we continue to grow as a company, our R&D pipeline is focused on helping meet the unmet needs for those patients in those communities as well. So, and that's why we value our partnership with Research America, who's now in their 30th year of doing this type of work. And again, for those of you that are involved from the beginning, thank you very much for that as well. Equally as important, we're here to, as Mary mentioned, we're sponsoring the most crucial part of the meeting, your breakfast. Right? I know my colleagues at Celgene probably disagree because they're sponsoring lunch, but hey, I didn't establish it. Everyone says breakfast is the most important meal, right? So here we are. But no, on a more serious note, it is crucial that the research community, all of you here, convene for conversations and addressing issues that you've already started to talk about this morning with Dr. Redfield, these things that impact medical health research, public health, and we continue that work with the patients, their advocates, the research community overall, the academic institutions that you work with, the philanthropists that support that work as well, because the goal is to find solutions for these health challenges. So we applaud you for that. And with that, I want to congratulate again Research America under 30 years of incredible advocacy in this space. and we hope you'll enjoy the forum. And then really, truly, most importantly, is that the conversations we start today, we hope you continue to elevate those with your colleagues as you leave this and move forward at other meetings like this and even your other social activities that you engage in. So thank you guys very much. Appreciate it.